Now, as I said this morning, of course, these are my own views, but they are based on facts. I try to do that. We can have three main perspectives on the use of force in psychiatry, and I will use antipsychotics as an example because that is the type of drug that is likely most commonly used in force treatment. We can look at it in a scientific fashion. Does force do more good than harm? I am convinced that it doesn't, but it's difficult to document. It's a kind of indirect evidence. And ethics, is force ethically defensible? Certainly not. It violates informed consent, and antipsychotics kill and cripple many people. So to force people into treatment with something like this against their will is not ethically defensible. So I wonder why we haven't heard from medical ethicists. What are these people doing? This is far more important than a lot of their nitty-gritty daily work. Then we have the legal aspects. There are international declarations that forbid us to have forced treatment in psychiatry, but they are being ignored. And if laws are unjust, we simply must change them. It's very simple. So I believe we cannot defend forced treatment scientifically, ethically, or legally. First of all, what about the benefits versus harms? As Bob Whittaker said, these drugs are not specific in any way, and the placebo-controlled trials are highly flawed. You have heard a lot about this. Lack of blinding, cold turkey in the placebo group creates a lot of harm. And despite all these flaws, the effect in recent submissions to the FDA of these newer agents like olanzapine, risperidone, and drugs like that, what you found in these submissions was an effect compared to placebo of 6 points on the positive and negative syndrome scale. And what is the bare minimum difference people can perceive as a change? That is 15 points. So like with the Hamilton Depression Score, what you see with these newer drugs is less than what people can barely perceive. And what people can barely perceive as a change, is that clinically relevant? I don't believe it is. If you can see light for the end of a tunnel, you can say, yes, I can see light for the end of the tunnel, but I still can't read my newspaper because it's too dim. And please consider that the diagnosis can be wrong in more than 50% of the cases. So a lot of these people even don't have schizophrenia, and then you enforce drugs on them that might kill or cripple them. This is simply something we should be terribly ashamed about. So I cannot understand this just goes on. Then we could ask, what about the benzodiazepines? I said a little about it this morning. The psychiatrists have failed to live up to their professional responsibility because they have neglected to perform head-to-head comparisons between benzodiazepines and antipsychotics. Why didn't they do that? Because they let the drug industry do almost all the trials. They have failed us and their own patients. 35 years after the first antipsychotic chlorpromazine came on the market, only 2 trials had compared these 2 types of drugs, and these trials showed similar improvements. There are now more trials, and a Cochrane review that showed that sedation occurred more often on benzodiazepines. That was 14 trials. They weren't of any high quality, but if the psychiatrists feel they are not good enough, they have an even more compelling reason to do them well enough. So perhaps we could get rid of antipsychotics altogether. Benzodiazepines are not nice either, and this may be my personal preference. If I were to receive anything, I would definitely prefer benzodiazepine and not an antipsychotic. These are horrible drugs. I can see some people in the audience who have tried both. They are nodding. You can call this anecdotal. That's up to you. There is a huge but deeply flawed Cochrane review. It reviewed chlorpromazine against placebo for schizophrenia. There were 5,500 patients. The abstract says that akathisia did not occur more often on chlorpromazine than on placebo. There were no reservations against this observation. And the largest trial that contributed data to the review found significantly less akathisia on drug than on placebo. How is this possible? Antipsychotics cause akathisia. Placebo cannot cause akathisia unless you introduce a cold turkey in the placebo group, which is exactly what you did in these trials. Can you imagine any worse science than this? Well, I can, but it is bad. So this result speaks volumes about how flawed trials in schizophrenia are. So we saw these cold turkey symptoms. Now here is a much better Cochrane review, because these authors realized that we need people who have not been treated before. So they went after early episode schizophrenia, but unfortunately with a majority of first and second episode schizophrenia spectrum disorders. So these trials were still flawed because some of these people were already in antipsychotic treatment. He wasn't first episode schizophrenia. But what they concluded was that the available evidence does not support a conclusion that antipsychotic treatment in an acute early episode of schizophrenia is effective. And moreover, the use of antipsychotic medications for millions of people with an early episode appears based on the evidence for those with multiple episodes, which we know this evidence is completely unreliable. So here we have some Cochrane authors that say, what on earth is going on? But we don't see many of these lights, unfortunately. So this is a terribly important Cochrane review. Antipsychotics kill people, and we can't rely on these usual trials. And I told you before that therefore I looked into trials in people with Alzheimer or dementia who were treated with these new antipsychotics, and I also told you that for every 100 patients treated, there was one additional death on drug. I think this is so important that it deserves to be repeated, actually, this result. This is the most reliable information on deaths caused by antipsychotics that I think we have. 1 in 100 are killed, at least among the elderly. Now, those who don't die, they are often crippled by antipsychotics that cause irreversible brain damage in a dose-related fashion, less chance of getting back to normal life, dependency, abstinence symptoms, supersensitivity psychosis, and a lot else. Some of the most toxic drugs ever made, apart from chemotherapy for cancer. So is force ethically defensible? A few hours or days of disturbed behavior can be treated as a course for lifetime sentence to drug treatment. And psychiatrists in training will, as Bob said, hardly ever see a patient who is not already snowed under with drugs, and therefore get a wrong impression both of patient and the strength and the potential for cure without drugs. All these bizarre behaviors that we relate to schizophrenia are usually caused by drugs. I didn't know that before I started to study psychiatry. We were all fooled. Some psychiatrists feel they cannot live without forced treatment, but think of the patients, they cannot live with it. Some die from it, actually. That's far worse. It's not defensible because it's only soldiers at war and psychiatric patients that are forced to run risks against their will that might kill or cripple them. And power corrupts, and the power imbalance is extreme. There is a high risk that forced treatment is being used to benefit staff rather than patients in order to make their work less stressful. Antipsychotics have killed hundreds of thousands of people and have crippled tens of millions. Some patients who were killed have begged what they call their torturers not to get the drugs. And very few have been investigated for slow metabolism, although this is what kills some of them. And here is a heartbreaking story, and the mother who wrote this book is here today. It's a story about how psychiatry killed her daughter at age 32 after her 14-year so-called career in psychiatry. She was a slow metabolizer, but her psychiatrist refused to have the test done. When Louise's best friend dropped dead on the floor at Amager Hospital, Louise said, "I'll be next." Few will believe in forced treatment after having read this book, so please read it. The diagnosis was wrong. The psychiatrists didn't listen, not even to their own staff who knew Louise much better than they did. They didn't listen to Louise's mother. They consistently blame Louise and her mother, never the drugs or themselves. And they increased the dose when it should have been decreased or stopped altogether, very consistently. When Louise was dead, the system congratulated itself for its first-class homicide. Louise had received what was called the highest standard of specialist treatment. And the cause of death was called unknown. You don't suddenly drop dead at the age of 32. That's very uncommon. The officially accepted term for such deaths is natural death. Danish researchers have shown themselves that psychiatric hospital contact seems to be pretty harmful. There is a Danish register study that showed that the closer the contact with psychiatric staff, which often involves forced treatment, the worse the outcome. Suicide risk was 44 times higher for people admitted to a psychiatric hospital compared to no psychiatric treatment in the preceding year. And most of the potential biases in the study actually favored the null hypothesis of there being no such relationship. Of course, you would expect that people who are more ill gets more admitted to hospital and therefore commit suicide. But actually the biases in this study went the other way around, most of them. So there was an editorial that said it's entirely plausible that the stigma and trauma inherent in psychiatric treatment, particularly if involuntary, might cause suicide. This is what the patients know, that when you take the last hope from a patient, that now we are going to put you in belts and force drugs into you that you are afraid of getting, and at the same time perhaps telling people this is a disease you will have for the rest of your life, and you will continue with these drugs for the rest of your life. What is left for a person like that? Why do psychiatrists so often, I've heard this so many times, take the hope from patients by telling them this is for life? Why do they do this? This is bad medicine. Now, I know a lawyer in Alaska who won a Supreme Court case. It decided that the government cannot drug someone against their will without first proving by clear and convincing evidence that it is in their best interest and there is no less intrusive alternative available. This is Jim Gøtzsche, a previous patient who has also been subjected to forced treatment. And he used scientific evidence to convince the judges. In another case, the Alaska court decided that if an alternative is feasible, the state has to either provide it or let the patient go. Psychiatrists with a full understanding of the trial judges regularly lie in court to obtain involuntary commitment and forced medication orders. The judges accept these lies. Everybody accepts the lies, it seems. So the show goes on. And I was just told in the break that the Norwegian High Court case I'm involved with has been rejected because there is nothing of principal importance in this case, they say, at the Norwegian High Court. We must battle against this with all the force we have. We must make lawsuits, must convince the lawyers that it's not in the patient's best interest